Dear Chair, dear audience, let me introduce my PhD title, which is Artificial Intelligence in Oral Medicine. Let me introduce myself first. I'm Dániel Horváth. I'm the prosthodontist and also a PhD student. My department is the Department of Oral Diagnostic and the Semmelweis University. My vision is to provide an artificial intelligence-based guidance for clinicians to help to treat and diagnose oral medicine patients. And my mission is to verify AI as a reliable support for clinicians and find the possibilities and the limitations of this technique. To achieve it, I right now have two specific goals. Let me introduce the first one, which is investigating the diagnostic accuracy of artificial intelligence in oral potentially malignant disorders. And to achieve this goal, we use the methodology of the systematic review and meta-analysis. So oral cancer is an urgent problem nowadays because almost 400,000 new cases every year and almost 200,000 deaths. This is the sixth most common cancer worldwide, and in Hungary the incidence is leading, so we are the third worldwide. But what is the problem? The problem is that we diagnose those lesions in later stages, and we do so, the 5-year survival rate is only under 40%. But even if we can diagnose those lesions in the first or second stage, the 5-year survival rate can jump up to 80%. But what is better? The better is prevention. So what can prevent oral cancer? To diagnose the parameters. So, for example, oral potentially malignant disorders, which has worldwide prevalence a bit less than 5%. Right now, we have an experience-based diagnosis, which can lead to diagnostic errors because the lack of accuracy. And if we can diagnose those lesions, they are treatable, and these diagnoses, we can save thousands of lives. And right now, we have AI as a new tool, which are able to process medical data. So our aim is to investigate this new tool, the artificial intelligence, as a new support for clinicians and this accuracy in the diagnosis of oral potentially malignant disorders. This leads to our clinical question that what is the diagnostic performance of AI in oral potentially malignant disorders? We use the PERT framework, and we hypothesize that artificial intelligence can diagnose OPMDs with the same accuracy as histology can. We used this search key on 5 main databases, and we ended up with almost 12,000 articles. Unfortunately, at the end of the day, we find 6 of those eligible. So let's jump to the outcomes. As a diagnostic accuracy study, one of the outcomes was the sensitivity and specificity. First of all, we need to know that all of the eligible articles worked with at least 2 different types of AI-based tools. Therefore, because of the overlapping population, we just picked the best performing one, and this table you are able to see the best performing one regarding the sensitivity. And the overall performance of these AI-based tools regarding sensitivity was 0.93 with a strong confidence interval, and the specificity was 0.94. But we need to evaluate these values in the daily practice, but how can we do this? We need to compare that to the workers on the field, so the general practitioners and the specialists. And we can see that regarding the sensitivity, in both cases, we have a statistical significantly better values made by the AI. Regarding the specificity, we couldn't reach the significance goal, but since we have some potential in this. But which is more important are the predictive values and the likelihood ratios. Why? Because by these values we are better, we can evaluate these architectures better. You may notice that we have different type of prevalences because we used the study level prevalence at evaluating the PPV and MPV within a study, but the overall was calculated with the study level prevalence. That's why the positive predictive value is way lower at the overall than in the study level. And we also evaluated the likelihood ratios, which seems to be because the positive likelihood ratio is above 10 and the negative likelihood ratio is below 0.1. So we have strengths and limitations. All of the pictures that was evaluated was biopsy proven. We worked with high amount of pictures in all the studies, and we know basically everything regarding the architecture and the teaching settings. Our limitations that we work with low amount of studies, different teaching pictures and different amount of pictures used in the teaching validating phase of these architectures, and they use, unfortunately, the same teaching settings within a study for different architectures. Our conclusion is that AI is reliable for screening oral potentially malignant disorders on intraoral photos. Our implication for practice is that it could be a non-invasive screening for OPMDs that can cause less burden on special care. And on the other side, implication for research, we provide to make an OPMD-based database to develop new architectures, to improve the positive predictive value of these models, and to provide multi-class classification models which could be more reliable in the daily practice. Our manuscript is after major revision in GDR clinical and translational research. And my second project is the prognostic evaluation of diagnostic criteria in oral lichen planus on histological images, and it's going to be a registry analysis. So we are still working with oral potentially malignant disorders, but with subgroups, the most common types, the oral lichen planus and oral lichenoid reaction. Both of them have a bit less than 1% prevalence in the general population, and both of them have chance for malignant transformation. Right now, there are no specific histological signs which are known to differentiate between those two entities. There are many diagnostic criteria without a known prognostic value, and there are a significant amount of unprocessed data in this field. So our aim is to investigate the predictive values of different diagnostic criteria on histological images in OLP. So our question is that what is the diagnostic value of different diagnostic criteria in oral lichen planus? We use the PFO framework, and we hypothesize that Schwitt bodies and lymphocytes and epithelium have higher prognostic value in oral lichen planus. And our clinical implication would be a more accurate diagnosis. Right now we are at the data cleaning of this project. And in summary, I want to say that both of our projects is related to oral potentially malignant disorders, to diagnose those patients and to help them provide, not to provide to the way of oral cancer. My additional activities, I'm teaching oral diagnostics and oral medicine at the Department of Oral Diagnostics, and I had a poster presentation at a Semmelweis Symposium. I'd like to thank your attention with a quote from Albert Einstein: "Try not to become a man of success, but rather try to become a man of values." Thank you for your attention.
Could the images be a confounder factor?
Yes, for sure. In most of the studies, the supply with the pictures made by was standardized. So, but across the studies they were different. So, in some cases they used cell phones. In some cases they used photo machines. But there wasn't any special lighting or something like that. So they used just a simple white light, and that's all for the imaging.
And the second is, In the future, if it is implemented as an application, for example, do you think it would be possible to use cell phone images for that?
Yeah, right now is already one, as far as I know, already one available software in India, which can be used for such a thing that someone just take a photo from the lesion. It needs to be uploaded to the cloud, and you need to provide some medical data, anamnestic data, and this tool going to make you a suggestion to go to the specialist or not. So I think it has some negative aspects also, but I think the future going to be in that way.
I only have one question. Maybe do you know that how the AI tools were developed to the certain projects?
Mm-hmm. Okay, so basically one half of the studies that used the AI was made from scratch, so from basics, so nothing exists, and IT developed the whole AI tools. And there are some projects from these articles where they used pre-trained models, and also only the last 2 or 3 layers of these architectures was added to this specific topic.
Which specific AI tools were they using throughout these articles that you mentioned?
Mm-hmm. So basically, as you saw, the name is not so informative regarding the tools, but all of the tools were convolutional neural networks, which are mimic the neural system of a human. So basically, they have 3 main parts. One, the first part going, when you input the data, it's going to extract the features of it. Then it's going to classify those, and after that, they're going to predict what kind of entity that could be, which are already. So before we know the categories we're going to sort in.
So you had 6 papers, right?
Yeah.
That you pulled. Did any of the papers publish their models that you can use?
Yeah. Models, I think, at least. So
I mean,
yeah. So
add
on
data
GitHub, on GitHub, lots of them are free source.
Okay.
So we can download those and use the exact same models. Just we can modify the teaching options of those models.
Okay. I have a very nasty question, and I have to be very sorry in advance.
Okay.
What's the benefit of pooling efficacy of these models if you're going to use them individually anyway? You're not going to use an ensemble of these models, right?
Sorry?
You're not going to use an ensemble of these models, right?
Yeah. So basically, we had it also in mind that at the end, as a conclusion, just say that use this architecture because this is the best performing one, and leave the rest because they not as good as that model. But unfortunately, it could be the case if we could compare the same model on different databases. Mm-hmm. So that's why we pulled them together.
Okay. Let me jump back a little bit of these softwares. The first group was back in 2019, I think. Right, the last one in 2023, so that's 4 years. Yeah. But I did not see much difference among these studies. So the system hasn't improved, or it was so good in that first time that not much left to do, or there is some difference which I haven't noticed.
So basically, in the first study from 17 is. More like a probability network than a real convolutional neural network, which is more likely working with different kind of texture shapes of the imaging, and it's less reliable. So it's a totally different procedure of working with the pictures than the newer architectures. So basically, as we coming closer to the present, that these architectures by calculation capacity, they're going to increase, but the hardware that needs for it are decreasing. So that's why even a cloud-based AI can make also the same precise calculation as the old models can, with much more bigger environmental need.
I'd value your opinion on these AI models, where they've been developed and whether or not they're appropriate for Hungary, for example. Are there genetic differences, epigenetic differences, and whatnot? And then, if that's, how would you actually validate or test that, and then, where to next to make this a valuable clinical tool here in Hungary?
Basically, I think it's right now in this current stage, it's only good for screening, so epidemiological screening, for example, because so in Hungary there are 4 medical universities, and these 4 medical universities are reliable for oral medicine patients, basically, and the rest of the country is so they are lacking this knowledge. And that's why they refer those patients to us even if it's not needed. Because it's even better than they don't refer it, because then oral cancer maybe could be a worsened problem than right now, but it causes a burden on us. And I think what we should focus on, that it's the negative likelihood ratio and the negative predictive value to surely can say that if the AI says that it's a negative, then it's a negative. And if it says it's a positive, we're surely going to make a biopsy and do the histology. So I think this is the way that we need to think about.